Our bony landmarks. So we have the greater trochanter where it attaches to, and it comes from the anterior surface of the sacrum. So if we find the apex of the sacrum down at the coccyx here, we come out to laterally to find the inferior lateral angle. So it's in line with the PSIS as we palpate. So if we find the posterior iliac spine there, we come down off it, and it really is roughly in line with that. So it's the angle of the sacrum as it then turns the corner and comes back up. So if we find the angle of the sacrum, the inferior lateral angle, the piriformis rises just above this or at the same position there as where you'll find the angle. So again, it comes off the anterior surface of the sacrum and then comes out laterally to the superior border of the greater trochanter. It's quite deep as it comes off the sacrum, and as we palpate the muscle and move laterally, we'll feel the tendon of the muscle as it attaches into the superior border of the greater trochanter muscle, and we'll remove the tape off the backing and let the initial anchor settle to zero tension before placing it on the sacrum. From here, we'll remove the backing off to our final anchor, stretch the tape out to 25 to 35% tension before laying that on the muscle. At the final anchor, we roll the tape off the backing, let it settle to zero before applying it to the greater trochanter. Rub the tape to activate the glue, and once we've completed our strength application, we'll make sure to reassess the muscle for any changes in strength as well as any functional gains. There at the attachment there, the femur moves away from the origin of the sacrum, lengthening the tissue. So from here, we can feel for the resistance of the movement. And of course, we're going to compare that to the other side. The initial anchor settled to zero tension before placing it on the greater trochanter. We roll the tape off the backing with 15 to 25% tension, and then let the final anchor settle to zero before placing it on the sacrum. Rub the tape to activate the glue, and once we've completed our taping, we'll reassess the muscle for changes in length, as well as any strength changes if that was.
Go ahead and close your eyes. Close your eyes and tell me when you feel it. Where you feel the sensation. Close your eyes. Where is it? You have to say where.
My forehead.
Okay, close your eyes.
My chin. Cheek.
Yeah, so everything sounds normal, and then go ahead and stand up. And then just go ahead and balance and maintain your posture for 20 seconds, closing your eyes with legs straight.
Huh?
Close your eyes and legs straight for 20 seconds. Close your eyes for 20 seconds. Okay, 20 seconds, so he maintained a balanced position, which is normal. So before we're ending the assessment, have you go ahead and palpate your lymph nodes, okay? So I'm going to go ahead and start right here, and then go poster recto, septo. I'm looking for any hard lumps or anything inflamed, which there's nothing. Do you feel any pain?
No.
Okay, and then I'm going to go ahead and feel for your carotid artery. So I'm just going to go ahead and feel for your pulse. Where is it? Now can you feel for your pulse? I'm straight on my shoulder, and I'm just going to go ahead and do this across your eye, and making sure I'm not staying for too long, and the pupils did react, and they're equal, and they're reflected to the light. I'm going to go ahead and test your accommodation by doing this. Just go ahead and follow the pen. Alright, perfect. And then I'm going to go ahead and document whatever I found. Next one is I'm going to go ahead and look at the ears. So I'm going to go ahead and palpate the ears. Is there any pain or tenderness?
No.
No? Alright, so there's no pain, there's no redness. I'm going to go ahead and look inside for any swelling. There's no...
Number one.
Alright, so I'm looking at the hair. The head, it's normal size, and there's no any abnormalities, and there's no any... Oh, the head is normal cephalic, which is a normal size.
Down, below, and to the side of the breast. Continue searching the abdominal area to the outside of the body with the palm of your hand. Reposition yourself behind and to the right of the individual. Reverse the placement of your hands and repeat the procedure on the opposite side.
Left hand at the offender's shoulder level, and use the bladed hand to search the upper chest, above the breast, and search across the top of the chest from the center of the chest outward. Place the thumb ridge of your left hand at the center of the chest. and with the back of your hand, search below and to the side of the breast. Then with your palm, search the abdomen out to the side of the body. With your left hand, squeeze the band around the waistline from the front to the back.
Starting with the core sensation, say yes for me with your eyes closed if you feel anything. So, doing it bilaterally.
Yes.
Okay.
Yes. 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 Yes.
Okay, thank you very much. So coarse touch was positive above the mid-chin. To the patient, what I'll be doing first. So Dr. Kamran, I'll be moving your thumb and then your ankle up and down. So the thumb I will move like this. This will be up and this will be down. Okay, I would like you to close your eyes and let me know if you feel it up or down. Okay, similarly I might do it on your ankle as well. So for the ankle, this would be up and this would be down. Okay, and let me know if how you feel it up and down. Okay, if you could please close your eyes now. Now
This is down,
okay, and what do you feel now?
up,
Okay, and now?
down,
Okay, and you need to check bilaterally. So where do you feel your thumb now?
down,
Okay, and now?
up,
And now?
down,
Okay, and where do you feel your foot now?
up,
Okay, and now?
down,
And now?
up, down.
So the proprioception was impaired in the toes, but it is normal in the ankles. Moving on from proprioception, we will be checking the vibration.
Approximately 1 centimetre. The skin should not be jabbed with the monofilament. The monofilament should be held in position for 1 to 2 seconds and then slowly released over 1 to 2 seconds. The patient should be asked to verbally confirm if they're able to feel the filament when it is introduced to the test sites of the feet. This procedure should be repeated on all testing sites on both feet and recorded. It is important not to help, prompt, or lead the patient's responses.
Nice and loud, nice and clear, is that okay? So ready when you are, if you will, please, closing your eyes.
Yeah. 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 Yeah.
But again, just let the jaw nice and relaxed, just let it hang, so to speak. Just open your mouth for me, open your mouth for me. That's wonderful. And lovely. Wonderful. Sean, that marks the end of the examination. You can come in the hands.
As passively if needed. The MTP joint allows 40 degrees of plantar flexion and dorsiflexion. The PIP joints allow 50 degrees of plantar flexion. And the DIP joint allows 10 to 30 degrees of dorsiflexion and 40 to 50 degrees of plantar flexion. You can do this for all of the toes as needed. Important structure is the plantar fascia, demonstrated here in green. This inserts into the medial calcaneal tuberosity. Tenderness in this area can be found in plantar fasciitis.
Roll the tape off the anchor and let the anchor settle to 0 tension. Place that over the acromion for the insertion and roll the tape off the backing 15 to 25% tension towards the origin. At the end, let your tape settle to apply the final anchor on. Rub the tape to activate the glue. And once completed, reassess your patient for length. Test for the upper trapezius. Have your patient sit upright with their feet firmly supported. Rotate the head towards the opposite side and tilt the head back and over to the side that you're testing. Lift the point of the shoulder up and bring that towards the ear. Ask the patient to hold that position as you apply pressure downwards at the point of the shoulder over the acromion and force upwards over the occiput in a direction that's going towards the ceiling and back down again. So holding that position and pushing down with your arms as you push up with your other hand. This starts from the external occipital protuberance and runs down into the lateral 1/3 of the clavicle, coming down the spinous process, down to C7 and running across into the acromion. Orientate ourselves to the spine of the scapula and the scapula itself. The middle trapezius comes down from T1 to T5 and the lower trapezius comes down to T12, taking the arm up just to orientate yourself to the muscle through there as it runs up into the spine of the scapula.